Is that working?
Yeah, perfect.
Okay, I'll stop sharing then.
Yeah. Great, thanks, Nim. I'll give it a couple more minutes. I know more people are just joining as we go, so Mahmood is going to rejoin as well. I think he's having a problem with his camera, so he's just firing and rejoining.
Right.
He just sent you
said that
another.
you hadn't been that well. Are you,
yeah, I don't know. You know what? It's one of these sort of. I presume it's viral, although it's not. Doesn't seem to be COVID because the tests have all been negative. But it's certainly knocked me back a bit this week. It's man flu plus plus. But yeah, getting over it now. I think there's been quite a few people I've spoken to who've had some things, so I don't know what's going around at the moment, but
yeah.
It's been a little bit like COVID in that you feel like you wake up thinking, okay, I'm feeling a lot better today, and then you kind of get knocked back. Yeah. Hi everyone, thanks very much for joining. We're just giving it a minute or two more just to let others join as well. Hi everyone, great to see so many people joining. More and more people coming every time for every meeting, but also just this morning I've seen more and more names appearing. In the interest of time, we might just get started, and others can join it as they link in as well. So everyone probably knows perhaps who I am. I'm Neil Patel. I'm a neonatologist here in Glasgow, and I had the pleasure this morning of introducing Dr. Nim Subhidar, who's going to speak to us today on acute pulmonary hypertension in the neonate. And the talk is entitled Back to Basics. Many of you will know Nim already. He's really a leader, I think, for all of us in the UK in neonatal hemodynamics, and particularly in the field of pulmonary hypertension. Nim's a consultant neonatologist at Liverpool Women's Hospital and also clinical lead for the Cheshire and Merseyside Neonatal Network. And he's been researching and applying clinical knowledge in neonatal hemodynamics and specifically in pulmonary hypertension for many years now, originating back with his MD, which I think Nim was in the field of pulmonary hypertension and inhaled nitric. Is that correct?
That's it. Yeah, many years ago.
And as many of you will know, until recently, Nim has also been chairing the European Inhaled Nitric Oxide Registry, and along with many of our international collaborators and networks, continues to lead initiatives in the field of neonatal pulmonary hypertension. So we're delighted to have Nim speaking to us all today, and really looking forward to this presentation. Nim, hand over to you. Thank you very much.
Great, thank you very much, Neil, and good morning, everyone, or just afternoon. Let me just check I can share my screen first of all. Can you see that? Great. Okay.
Yeah. Thanks, Nim. We can see that.
Okay, great. So I wanted to choose a title which didn't include anything about echocardiography, because usually this group are well versed in matters to do with echocardiography and know far more than I do in terms of pulmonary hemodynamics and assessment of ventricular function. So I wanted to put a slightly different spin on a talk about acute pulmonary hypertension. So these are the themes of my talk. And when I say go back to basics, I want to talk a little bit about the definition and classification of pulmonary hypertension in the newborn. I'm going to review some basic hemodynamic principles of pulmonary hypertension and try and illustrate why they might be important in the day-to-day care of our babies. And then touch on why some babies don't appear to respond to treatment. And I'm going to focus on nitric oxide because it's our first and foremost treatment in neonatal pulmonary hypertension. So to start with definitions, well, I can summarize this by saying there isn't a clear definition of pulmonary hypertension in the newborn period. And unlike adults and pediatric pulmonary hypertension, you can see this, this frame on the left-hand side, they have very clear definitions and they have the benefit of being able to categorize their children and their patients. And they have a cutoff of mean pulmonary arterial pressure of 25 millimeters of mercury, and that's been revised downwards now in adults, and the pediatric community is following suit. So the threshold is down to 20 millimeters of mercury of mean pulmonary arterial pressure as being the definition. But you can see that even their definition only applies to children and young infants who are over 3 months of age, which is a nod, I think, in recognition of the fact that it is difficult, or there's no agreed consensus about the definition in younger infants and neonates in particular. And this is illustrated in a piece of work that we did in Liverpool. One of my colleagues, Emily Hoyle, looked at all of the clinical trials, all of the randomized controlled trials of pulmonary hypertension using nitric oxide, and to try and describe the various definitions, the echocardiographic definitions. And as you can see, there are a variety of different definitions used in all of the studies. And this variation probably illustrates that we haven't, as a community, got an agreed definition of what we mean by neonatal pulmonary hypertension. And one of the problems, one of the difficulties in defining pulmonary hypertension is that there is a changing landscape in the newborn period. So we know in fetal life that pulmonary vascular resistance and pulmonary arterial pressure is changing week by week and month by month. And then at the point of birth, there's a rapid transition. And if there's a normal cardiovascular adaptation, then pulmonary vascular resistance and pulmonary arterial pressure will fall quite dramatically. But a lot of our babies are babies that we deal with who are very preterm, and there are a number of different factors that are going to influence pulmonary hemodynamics and pulmonary arterial pressure changes at that time. So this is a study that comes from Florida. It's a single center study looking at extremely preterm infants. I think it was below about 29 weeks gestation. And what they did was they followed these babies up. It was a prospective study, so they followed these babies up with echocardiography at regular intervals every 2 days over the first 14 days. And it looks quite complicated here, but they identified 5 different patterns illustrating the natural history of pulmonary arterial pressure during that time frame. And what I've done is I've tried to describe these in a sort of basic diagrammatic fashion to illustrate what happens to pulmonary arterial pressure in this time frame. So there are 5 patterns, as I said, in the preterm baby after birth. And they diagnosed pulmonary hypertension when they had measurable pulmonary arterial pressure, which was more than 50% of systemic pressure. So the first 2 are where pulmonary arterial pressure falls to normal down here by 14 days. But in one group, about 1/3 of all of their babies, it falls pretty quickly and then remains low throughout the rest of that time period. In another group, only 10%, but in a significant minority, pulmonary arterial pressure does drop to normal levels, but it takes time. There's a delayed transition, delayed cardiovascular adaptation, but these babies do achieve normal pulmonary arterial pressure, but it takes longer in that group. Then there are two other patterns. One where after an initial normal period of cardiovascular adaptation, there's a secondary rise. So this is group B here, again, a small minority. And a fourth group where the pulmonary arterial pressure appears to fall, although there may be some delay in that fall, only for it to then rise by the end of the second week. And finally, the fifth group, which we see from time to time, is where the pulmonary arterial pressure starts high and remains high essentially throughout the first 2 weeks of life. So I think it's important to understand the different patterns of cardiovascular adaptation in this group, because to my mind, there are two sorts of pulmonary hypertension that we should be thinking about, and not all pulmonary hypertension in the newborn period is the same. So I would advocate distinguishing acute pulmonary hypertension from chronic pulmonary hypertension. And when I talk about PPHN or read about PPHN, I'm thinking about this group here. So babies who don't adapt normally to extrauterine life, where pulmonary vascular resistance, we assume it remains high, and pulmonary arterial pressure therefore remains high. And this is the group that I'm going to focus on. And I prefer the term acute pulmonary hypertension really to PPHN. Having said that, we do use the term PPHN, so we need to understand where it comes from and what it means. And this is the first description, the first report of PPHN that I could certainly find. This comes from 1969, and this is the abstract. And as you'll know, that this previously used to be called PFC, persistent fetal circulation, rather than PPHN. But I think this is important, this phrase in the abstract where it says, so they describe two term babies who had severe hypoxemia and a particular pattern of pulmonary hemodynamics. So it says, in each instance, there was severe pulmonary hypertension to systemic levels or above, and large right to left shunts at both atrial and ductal levels. And I think that's important because, to my mind, this describes PPHN physiology, which is a term that some of you will have read in papers. And what that means is this suprasystemic pulmonary arterial pressure with an extra pulmonary right to left shunt, either at ductal or typically both at ductal and atrial level. And this comes about because of persistently raised pulmonary vascular resistance. So pulmonary vascular resistance is high in the fetal circulation, and it remains high. It doesn't adapt appropriately following delivery and birth. Not only do we need this sort of pattern of pulmonary hemodynamics, but we also need that to be twinned with severe hypoxemia. So I'm not putting numbers on this, but I think you need to have a degree of hypoxemic respiratory failure if you really are going to have a syndrome of PPHN. And finally, and this is what I was alluding to in my previous slides, is that this picture needs to be apparent and a problem in the first, let's say, 48, perhaps 72 hours after birth. And that means, and I want to emphasize this, that not all pulmonary hypertension in the newborn period is PPHN. So it's only that which declares itself in the first 48 to 72 hours and has all of these features alongside that I would then accept as being PPHN. Okay, so I think we need to be a bit clearer about our definitions, because when we come to enrolling babies into clinical trials, we need to be speaking the same language so we know the sort of babies that we are treating and evaluating. So in terms of incidence of neonatal pulmonary hypertension, well, clearly it depends on the definition you use. And this slide comes from a Californian study. And this is probably the best data we have because it's a population-based study rather than coming from a single center or even a network of centers. And they used registry of deaths and births to try and identify the incidence of PPHN. And when the cause of death the sort of diagnostic criteria were one of these, then it was accepted that the baby had what we would assume as PPHN. Clearly, no echocardiographic criteria, but just a clinician stated diagnostic code. And the incidence there was 18 per 1,000 term and near-term babies. So these are babies who were 34 weeks gestation or greater, and not just term babies, so term and near-term babies. So that translates into incidence of 1.8%. And they showed that pulmonary hypertension, or this PPHN, was associated with an increased one-year mortality of 7.6%. And there was a relationship, even in this group of term and late preterm babies, of increased incidence and increased mortality in babies who were more preterm. They also created these survival curves where they looked at different underlying etiologies and showed that there was increased mortality in babies with, so this is congenital malformation, and this is specifically CDH. So those babies with PPHN, as you might expect, do the worst. So this is the best information we have about incidence of acute pulmonary hypertension, or PPHN as it was coded in this group. But there are other ways of classifying pulmonary hypertension in the newborn period, or actually this is the pediatric population. So this comes from the PPH-NET registry, which is a collection of, I think it's about 8 or 9 North American centers. So it's not a population-based study or even an international registry. It's a network of big academic centers in North America. And this on the left-hand side is called the WSPH classification. That's the World Symposium of Pulmonary Hypertension. And this classification comes from, I think it's 2019. And you can see that there are 5 groups. Within those 5 groups, there are certain subgroups. And the ones that are relevant to us as neonatologists and pediatricians are these. So 1.7 here, persistent pulmonary hypertension of the newborn syndrome. 3.5, developmental lung disorders, which include, pulmonary hyperplasia, congenital diaphragmatic hernia, those sort of things. And perhaps left ventricular failure. And I'll talk a little bit more about that later on in my talk. So this pie chart here gives you some idea of the split of different underlying causes of pulmonary hypertension in the pediatric population. And you can see that PPHN features, but not that commonly. So this is a subgroup of group 1. But BPD associated pulmonary hypertension and pulmonary hypertension complicating CDH comprises a considerable proportion of group 3. So these are important. That our neonatal population and neonatal pulmonary hypertension is important in the wider realm of pulmonary hypertension in pediatrics. And there are other ways of classifying pulmonary hypertension in the neonates. And I think this is probably something that we might feel more comfortable with. And this comes from Amish Jain's group. It was a review article a few years ago now, but I still think it's useful from an etiological perspective and also in terms of timing. So they've split their group into acute or chronic, as I was advocating earlier on. And within the acute group, you can see that they're further subdivided into reversible and irreversible. And then you have a variety of different diagnostic criteria, if you like, underlying etiologies that are separated out under those subcategories. So this is another way of describing and classifying pulmonary hypertension in our population. Okay, So I did say that we were going to go back to some basics, and we need to understand what we mean by pulmonary hypertension, which is essentially, in a simple, to describe it simply, is raised pulmonary artery pressure. And you know that pulmonary arterial pressure and pulmonary hypertension is the product of pulmonary blood flow and pulmonary vascular resistance added to pulmonary capillary wedge pressure, if you like, left-sided, left atrial mean pressure. And we need to recognize what the determinants of each of these different variables are. So, for example, pulmonary blood flow is going to be influenced by right ventricular output, but as well as that, any left to right ductal shunt that a baby might have. And pulmonary vascular resistance has a complicated relationship. Not only is it influenced by viscosity and the length of any connection. So if you've got a duct, for example, vascular resistance will be determined by how long that duct is, but mostly by the radius of the tube that we're talking about here. So pulmonary vascular resistance or ductal resistance, the radius to the power 4 is what's going to be important in determining pulmonary vascular resistance. And then finally, as I said earlier on, pulmonary capillary wedge pressure is going to be determined by left atrial mean pressure, which should be the same as left ventricular end diastolic pressure. And that's really a surrogate of left ventricular function. So if you've got left ventricular dysfunction, you will have raised left ventricular end diastolic pressure, raised left atrial mean pressure, and that will ultimately increase your pulmonary artery pressure because your pulmonary capillary wedge pressure will be increased. So all of these are important determinants. And what we need to understand and think about when we're faced with a baby who has pulmonary hypertension is which component of this is to blame, if you like. So let's think about pulmonary vascular resistance, first of all. During normal cardiovascular adaptation from fetal to neonatal life, we have a change in our small pulmonary arterioles. So this is a cross-section through one of those small arterioles. L is the lumen. You have these endothelial cells, and then the smooth muscle cells behind those on the towards the serosal surface of the vessel. And within a few hours, and certainly by 24 hours, there is a relaxation of the smooth muscle. There's a flattening out of the endothelial cells, and the lumen of the blood vessel will increase. And we know already how important the radius of any blood vessel and collectively of all of the blood vessels is going to be, because it reduces resistance by the power 4. So this normal transitional circulation, normal adaptation is very important in reducing pulmonary vascular resistance. And this is important from our point of view when we're dealing with babies with PPHN, because babies with PPHN don't adapt in this way. In fact, they persist with this normal I know it says newborn, but this is essentially the fetal pattern where you have a small lumen, increased pulmonary vascular resistance. And these two slides show how muscular, first of all, the pulmonary arterioles are and how far the muscle extends down the arterial tree, and what the difference in the luminal size is because of that muscular and endothelial thickness. We'll just go back. And from a management point of view, we also need to be aware that things that we do in terms of mechanical ventilation and lung inflation will impact on pulmonary vascular resistance. And many of you will have seen this sort of slide, which shows pulmonary vascular resistance on the y-axis and lung volume on the lung volume on the x-axis. And we try and maintain optimal lung volume around FRC, because low lung volume and high lung volumes are both have a negative impact on vessel diameter and therefore vascular resistance. So part and parcel of our management should be to try and optimize pulmonary vascular resistance through maintaining an optimal lung inflation. Right, I'm just going to pause there because I can't see if there are any hands up. I might be talking to myself here. Just want to check that you can still hear me okay?
You're right, Miles, you're right.
Yes, we can.
Yeah,
Right.
thanks, Nim.
Okay, sometimes you feel you're just talking to yourself, but that's great. Okay, so that's one component, and probably the most important component when we're talking about pulmonary hypertension, because if we're talking about PPHN in particular, pulmonary vascular resistance is probably the most important determinant of pulmonary hypertension. But another component that's important is what's happening to the left ventricle and what's happening to pulmonary capillary wedge pressure. So as I said earlier on, this is determined by what's happening to the left heart and left ventricular dysfunction. And until fairly recently, we've been thinking about the right ventricle and the impact of the right ventricle, and thinking about offloading the right ventricle by reducing afterload with pulmonary vasodilators. But the importance of the left ventricle and the role that it plays in this condition, and as we will see shortly in babies who don't respond to treatment, is becoming more and more apparent. So I don't think we can ignore this. In fact, I don't think we should ignore it. We should be looking out for babies who have left ventricular dysfunction and in whom pulmonary hypertension, where this raised left-sided pressure might be impacting on pulmonary hypertension. And thirdly, and this is really just a completeness really, it's not something that's likely to be a problem in the acute phase of pulmonary hypertension, but there's an increasing recognition also that increased pulmonary blood flow, even when you haven't got increased pulmonary vascular resistance, may lead to pulmonary hypertension. And the clinical picture usually that faces us is a baby with a PDA with a large left to right shunt through an unrestricted ductus, and in whom the pulmonary pressures, either acutely or more likely chronically, are raised because of flow-related pulmonary hypertension. There's too much blood flowing for the pulmonary circulation to be able to accommodate. So I'm calling this flow-related pulmonary hypertension. But the problem with it is that in the short term, it may not cause a problem, but if left unrecognized or untreated, then this increased blood flow is going to lead to ultimately irreversible increase in pulmonary vascular resistance through progressive and persistent muscularization of the pulmonary vasculature. Okay, so that's the three components of what is likely to cause pulmonary hypertension in our population. And I think when we're going back to classifications, it may be useful to think about from a pulmonary and pulmonary hemodynamic and cardiovascular function perspective to split acute pulmonary hypertension into either pulmonary arterial hypertension, which probably accounts for the majority of cases. So this is the PPHN picture where there's increased pulmonary vascular resistance. But to be aware that sometimes pulmonary venous hypertension, because of left ventricular dysfunction, might be contributory. Okay, so I'm going to change tack now. I'm going to talk about nitric oxide and treatment and non-responders to pulmonary hypertension therapy. So nitric oxide isn't a new drug, as you will all know. It's almost just over 3 decades old now. 1992 were the first side-by-side reports in the Lancet, small case series showing some potential for benefit and improvement in oxygenation. And then probably around 8 to 10 years later, there was a product license that was granted for nitric oxide in Europe, but it's only licensed for treatment of babies with hypoxemic respiratory failure and PPHN at or above 34 weeks gestation. So only term and near-term babies. And the evidence base for that group remains strong. In fact, there haven't been any recent randomized control trials. And we know that in that population, giving nitric oxide to those babies in acute hypoxemic respiratory failure, some of whom will have pulmonary hypertension as well, improves their outcome in terms of a reduced need for ECMO or a reduction in death. And it's quite a powerful effect with the number needed to treat of 5. So that's term and near-term babies. But the situation in preterm babies remains, widely debated. And many people believe that you shouldn't be using nitric oxide in this population at all. When you look at the meta-analysis, at best, in this population, there may be a borderline effect on BPD and death, but the evidence base isn't convincing, and there are plenty of people who choose not to use it in this situation. Having said that, the off-label use of nitric oxide in this population remains very high, and when we looked at it in the UK, just over half of all babies treated with nitric oxide were preterm below 34 weeks gestation. So there's a high off-label use of nitric oxide in our population. But the problem is that the response to nitric oxide, both in term and preterm babies, is certainly not universal, and it's normally quoted as being about 30% of babies don't respond, so 70% do. So I've looked up a few recent studies and summarized, these aren't all randomized controlled trials by any means, but these are recent data looking at both preterm babies, so the first 3 studies here are preterm babies, and the last 2 are term or near-term babies, and a variety of different underlying diagnoses. But the response rate is interesting because while some of it is expected, so for example, babies with CDH having a response rate of 40%, perhaps a little bit lower than you might expect, but we know that there's not very much that we offer babies with CDH that actually improves their outcome, and nitric oxide response rates are low. But it's quite interesting to see how response rates are quite low across the board, meaning that 40 to 50% of babies that we are treating with nitric oxide, be they term or preterm, don't show a short-term oxygenation response. And that's relevant because we know that responders do better. Depending on which study you look at, either survival to discharge seems to be improved in responders, or even long-term neurodisability is improved. And in term babies with CDH, there's a reduction in the need for ECMO, or some respiratory support parameters down here, duration of ventilation and oxygenation and oxygen therapy is improved in babies who respond. So trying to tease out the babies that are going to respond is important from a perspective of short and longer term clinical outcomes. So I want to talk a little bit more about a couple of these studies. So the first one is the study by Lawrence. So this is a single center retrospective study of babies just with CDH, the term and near-term babies with CDH, and they either had hypoxemic respiratory failure and or had echocardiographically confirmed PPHN. And what they found was, I've already told you this, that there were 40%, only 40% of them responded. And they split their responders split their babies into responders and non-responders. And they found that the babies that didn't respond to nitric oxide in this group, these babies with CDH, were those who had baseline evidence, this is prior to starting nitric oxide, of left ventricular systolic dysfunction. And they defined that as being a fractional shortening of less than 28%. So perhaps not the gold standard in terms of how you might assess left ventricular function, but certainly a measure of left ventricular systolic function, showing that if you had some evidence of dysfunction, then you were less likely to respond to nitric oxide. And not only that, having poor LV dysfunction in this group not only predicted oxygenation response, but was associated with more ECMO and fewer babies surviving. So LV function in this group of CDH babies is important. And a more recent study, so this is by the Iowa group, and I think it was when Iowa and I think it was a Canadian group, published a couple of years ago, this time looking not just at babies with CDH, but term and near-term babies with hypoxemic respiratory failure. The response rate was higher, as you might expect in this group, but when they looked at non-responders, again, they found that both LV function and RV function was associated, or dysfunction was associated with poor response. So this seems to be a theme that's emerging, that what's happening to your left ventricle and probably both your ventricles is important. And it's not just a matter of reaching for a vasodilator whenever you're faced with a baby with pulmonary hypertension. That may be the answer. If we want to tackle this cohort of non-responders, we may need to be thinking more widely. And when we look at preterm babies, there is also some evidence that baseline pulmonary hypertension is important. So a lot of the trials that I was showing you previously, the RCTs of nitric oxide in preterm babies, didn't distinguish between those with PPHN and those without. Most of them didn't have any baseline echocardiography at all. So this is a large study from the States, from the pediatrics group, so a network of probably larger neonatal centers. And they looked at the impact of using nitric oxide in babies with RDS. And the frame on the left-hand side shows that there was no discernible difference in terms of survival when nitric oxide was used in babies with PPHN. But when you look at babies with RDS without PPHN, what you find is something quite interesting. And that's the fact that without PPHN, babies who are treated with nitric oxide do worse. They have a lower survival rate. And this is shown in a increased hazard ratio of 1.67. So whether or not you have PPHN as a baseline, as a preterm baby with RDS, is likely to be important in terms of your response, your short-term response, and in terms of important clinical outcomes such as survival. And it's not just babies with RDS. This is a similar study looking at survival. So this was a propensity scoring analysis, and they looked at preterm babies, but this time with pulmonary hyperplasia rather than RDS. And again, they split their babies into those with PPHN and those without PPHN. So the first finding was that when you looked at babies without PPHN, there was no difference in survival in babies receiving nitric oxide or not receiving nitric oxide. But when you look at babies who had PPHN and got nitric oxide, there seemed to be a difference in survival. So babies who didn't receive nitric oxide but had PPHN did worse in terms of survival. So this is about 55% versus say 65%. And that was of borderline statistical significance, but still potentially of interest. And what this suggests to me, sorry, just one more slide before I summarize that. So this is yet another slide of preterm babies with RDS, more than half of whom had PPHN diagnosed. And what they found was in this cohort, and I think this was an Italian study, they found that, again, short-term response was independently associated with baseline PPHN. So all of these last three studies are saying the same thing, that having, whether you have or don't have PPHN as a preterm baby is important in terms of your response, both short and longer term response to nitric oxide. And my take-home message here is that we shouldn't be using nitric oxide, or for that matter, any other pulmonary vasodilator blindly in our preterm population. I think we should be cautious, especially because, at least in theory, there are likely to be some side effects of nitric oxide in this population, probably not completely defined as yet. But we should be saving nitric oxide for all those babies that are likely to respond best to it. And those, to my mind, are those babies with PPHN. However you diagnose as some, I would say, PPHN physiology. So a right to left shunt, so elevated pulmonary pressures to above systemic pressure, and a right to left shunt at ductal or atrial level. I believe in the importance of baseline echocardiography, because you're not going to be able to diagnose PPHN and identify those babies without it. But equally, it's important to make sure the underlying structure is normal, as well as assessing pulmonary hemodynamics. And finally, important for assessing ventricular function as a baseline before deciding whether or not to use nitric oxide. And the point being here that if we have clear evidence of LV dysfunction, then we should be supporting the left ventricle first of all, before resorting to a pulmonary vasodilator, because pulmonary vasodilation in that scenario is going to increase, it further can decrease pulmonary vascular resistance, increase pulmonary blood flow, and increase venous return to the left side of the heart. Now, but that might be okay if your left ventricle is working well, but if it's already failing and you increase the preload, you are going to tip that baby in the left ventricle into failure. And you're going to have a detrimental effect because of increased left atrial pressure and the appearance of pulmonary edema. And future clinical trials should tease out this group of babies instead of just randomizing all comers, all preterm babies with hypoxemic respiratory failure. We need to pick out the ones who are hypoxemic and have PPHN physiology and don't have left ventricular dysfunction or have left ventricular dysfunction that's been adequately treated and addressed prior to using a vasodilator. So I think this is important. It's emerging and people are recognizing the importance of LV dysfunction and PPHN physiology in this group. And then what do you do if you have a baby in whom you've started nitric oxide and that baby hasn't responded? So we know that 30, 40, 50% of our babies aren't going to respond. So where do you go to from there? And this again comes from a review from Amish's group, which looked at the importance of echocardiography for confirming the presence of acute pulmonary hypertension. And then in those babies who don't have an adequate response, to then have future treatment with inotropes and vasopressors based on what they've said here is low systemic arterial pressure, which should dictate which agent you choose. I think I would go beyond that. Firstly, I would highlight the importance of structural echocardiography. So especially in term babies who are not responding to nitric oxide when you think that they should be responding. And we've had one of those babies recently at Liverpool. We were at pains to try and ensure that the cardiac anatomy, the underlying cardiac structure of the heart was normal. And I don't think we should ignore that. And the other thing I would add to this algorithm is blood pressure, because there are some agents, and I'm thinking of things like milrinone and sildenafil in particular, where you might want to use them as adjuncts to nitric oxide as pulmonary vasodilators, but you might be reluctant to use them if you've already got hypotension and low ventricular output. So low systemic blood pressure, yes, but also an assessment of ventricular output is important. Now, there are some agents there which are relatively new, and we probably all use them in a slightly different way. We've been having a discussion in Liverpool recently about which agents, especially vasopressin and epinephrine, noradrenaline, we should be using and in which order and the rationale for doing that. So I'd be interested in hearing what you think, what the group thinks about these agents and what your experience is. But I thought I'd quickly just review the evidence base, and there are very few studies of vasopressin and noradrenaline. So I found 3 in a quick literature search. So this is the one that I think most people know about. This is a small case series, only 10 babies. These are non-responsive babies to nitric oxide therapy. So vasopressin was added in after non-response. And given the small numbers, we should take this with, there are some caveats to publish studies like this, but if it's the best evidence we've got, we ought to take it on board. And it shows an improvement in oxygenation index within a few hours of starting vasopressin in addition to nitric oxide. And there's another very similar study, which was published only last year. This is, again, 10 babies, refractory PPHN, started, just over 24 hours of age as a mean aged, and showed a very similar response. Within the first few hours of using vasopressin or adding in vasopressin to nitric oxide, there was a reduction in oxygenation index. But pretty low quality evidence, really, two very small retrospective case series. And the evidence base for noradrenaline is similarly weak. This is a much older study. This is almost 15 years old now, a retrospective case series. It was interesting because this was term and near-term babies who were hypoxemic, and the entry criteria were PPHN with circulatory failure, which were treated with nitric oxide. Now, interestingly, despite the nitric oxide, and in some babies, the FiO2 had decreased because the overall mean for this group was only 0.51, so 51% oxygen. So not necessarily the sort of babies that we might be considering treatment in, certainly not first-line treatment. But perhaps, depending on what they mean by circulatory failure, it may be relevant to us. But what they showed was interesting in the sense that there was a reduction in the ratio between mean pulmonary arterial pressure and mean systemic arterial pressure in this group after starting noradrenaline. So there's a reduction here. And at the same time, there was an increase in LPA blood flow velocity, which is a proxy for pulmonary blood flow, a very small but potentially important increase in pulmonary blood flow. So that's where we are with the newer agents, and I very much welcome your thoughts and your input into how you're using these two agents in babies with refractory pulmonary hypertension and circulatory issues, because we're struggling with this in Liverpool at the moment about knowing which drugs to use in which order. So I'm going to finish there. We've got a few minutes left for discussion, hopefully. I think this is what I've told you in this talk, that there isn't an agreed definition of pulmonary hypertension in neonates, and why there isn't an agreed definition and the difficulties of trying to achieve a consensus definition. I think the phenotypes that we touched on are important, whether it's acute or chronic pulmonary hypertension, what the underlying etiology is in terms of RDS, pulmonary hyperplasia, or CDH, what the cardiac and hemodynamic status in an individual baby is likely to be important. And all of those things need to be considered when we're thinking about pulmonary hypertension and an approach to management and treatment. I'm presumably just preaching to the converted here that I believe that our approach to the management of babies with pulmonary hypertension should be guided, I should say non-responders to treatment, should be guided by echocardiography. So thank you very much. I'll stop sharing, and I hope I've generated some interest and some discussion.
Thanks very much, Nim. That was fantastic, absolutely fantastic presentation. And I think you've taken us from a historical perspective of pulmonary hypertension as a single kind of entity and really broken it down and brought it up to current thinking around different pathophysiological mechanisms, the challenge around definitions, I think, as you described, but also help to frame very much where we are with current therapies and the appropriate use of those, but also the challenges around that. So just again, thank you so much for an amazing talk. I was making tons of notes and throughout that. Any questions from the colleagues present? I see a comment from Anne-Marie also thanking you for a great talk, Nim.
Well, can I ask you then, Neil, about vasopressin and noradrenaline?
Yeah,
It came about in Liverpool because some of our paediatric intensive care colleagues reached for noradrenaline first rather than vasopressin. And just our own custom in practice has been to use vasopressin rather than noradrenaline. We hardly ever use noradrenaline. I don't think we've ever used it really in PPHN anyway, perhaps septic shock. But what are your thoughts about that, and why and when do you choose one over the other?
Yeah, I can tell you my very personal thoughts, if that rather than reflective of us as a group, and I'm interested in everybody else's. Like yourself, I'm increasingly trying to use them in a pathophysiology-based kind of approach, and in the setting of acute severe pulmonary hypertension with LV dysfunction, I've always been very cautious about the use of systemic vasoconstrictors, just because it scares me to think that sometimes when the LV is so dysfunctional that increasing afterload on that is not going to be helpful. But there's two settings where we do use them. The first is not really pulmonary hypertension, although it may be coexistent, which is severe sepsis with low systemic vascular resistance, typically a gram-negative type sepsis, and that's where we have got experience of using both noradrenaline and vasopressin to support diastolic blood pressure in the setting of usually what is quite good cardiac function, but that's not specific to pulmonary hypertension. In pulmonary hypertension, in particular in congenital diaphragmatic hernia, I've used both recently in the setting of babies who have severe right ventricular dysfunction, either with good preserved left ventricular dysfunction or once the left ventricle has improved. And we're just developing experience in using vasopressin in that setting. I'm conscious, having spoken to colleagues internationally who use it, that one of the challenges around vasopressin is obviously other effects in terms of hyponatremia, fluid retention, generalized edema. So when we have used it, and certainly in the patient I used it in more recently, we used it for a pretty short duration when we had a combination of ongoing severe pulmonary hypertension, right ventricular dysfunction, and low diastolic pressure. And it was useful in that setting. And I used it before noradrenaline. Part of the reason was that in that particular patient, they were already on lower dose adrenaline, which had been on to support their left ventricular function, which was then improving. And rightly or wrongly, I just didn't want it to end up on two, really potent catecholamines, and preferred to use vasopressin in that setting. So that's my experience. Interested in other people's. I know we've had great presentation from Giza last week and previously from the guys in Oxford around their use of vasopressin in patients as well. So it might be relevant to hear that.
Now, to my mind, they're very similar drugs in terms of their potential, as I've shown you in the last couple of slides, that yes, there may be some beneficial effects on in terms of pulmonary vasodilation, and in the right babies, some beneficial effects in terms of systemic vasoconstriction and improving blood pressure. But I'm not clear in my own mind why I would choose one over the other. So
yeah,
that's if someone could describe a clinical situation where there's some rationale for choosing one over the other, or a better efficacy profile or safety profile, one or the other. But I'm not sure we've got the evidence base there to make those sort of decisions.
Yeah, I completely agree on that. On your point, I don't think we've got the evidence base to do that. We're for both vasopressin and noradrenaline, as you pointed out, we're basing it on historic retrospective case series in the main. And it may come down to individual and unit-based kind of experience and familiarity. As you say, sometimes in PICU environments, colleagues are more familiar with a different agent, so they're happy to use it. Yeah. I mean, again, I think it's interesting when you look at that, the evidence for noradrenaline in that setting of pulmonary hypertension. I think they showed that improvement in pulmonary to systemic pressure ratios, but to me, I've always wondered, was that because the systemic blood pressure was better rather than the pulmonary artery pressure was lower? So I don't know, but whether it's a pulmonary vascular effect or whether it's a systemic effect.
Yeah.
Thanks very much. Prakash has posted a colleague article in the chat there. Prakash, I don't know if you want to comment on that in relation to, is that PDA exposure and prolonged pulmonary vascular disease? Or any other comments or thoughts for Nim? Harsha?
Hi, Neem. Excellent
Hi.
talk. Thank you very much. I'm Harsha from Birmingham Heartlands Hospital. Neem, I have a question regarding your second slide. I think you showed us the pattern of pulmonary hypertension in the 5 patterns you showed us. I'm interested in the one which is in red, where the pulmonary pressure drops down nicely in the first 12 to 24 hours. And after 4 or 5 days, it starts rising gradually. Do you know, like, which group of babies, like, what is the pathophysiology, like, why the pulmonary pressure drops down and then it starts going up again? Any thoughts on that?
I can't tell you offhand without looking back at the paper, but the 2 thoughts I've got at that sort of pattern, what I would worry about is, one, whether there's a duct that was opening up and it was a flow-related pulmonary hypertension. So that's one thing I'd want to know. And secondly, with evolving chronic lung disease, we know that not all babies with chronic lung disease have much in the way of lung disease and pulmonary vascular problem early on, but it's something that develops over time. And that's been shown in prospective studies that have looked at the evolution of BPD, pulmonary hypertension, where there are some babies that start with, at, let's say, 2 weeks of age, will have established high pulmonary arterial pressure, and that remains high. Others will have low pressure at 2 weeks and then develop pulmonary hypertension by 36 weeks. So it works both ways. And so I think there must be a group of babies who don't have much in the way of perhaps respiratory disease and or pulmonary vascular disease, but in whom both of those evolve with time. And by 36 weeks, then they end up having chronic lung disease complicated by pulmonary hypertension. So those are the 2 things, either a ductal shunt or evolving chronic lung disease are the 2 things that would worry me about that pattern.
Okay, thank you. Because last week we had excellent discussion around pulmonary hypertension, and we did discuss some of the things about vasopressin, and we had a couple of interesting case presentations as well. And the small group where the cases were like, where the pulmonary hypertension was not there initially, but started appearing after a few days. And those babies were really, really sick, didn't respond to any nitric. So we were wondering, like, what was the reason behind after a few days why it appears back. Yeah.
Okay, no, I'm sorry, I missed that. Was that was last week's talk, was it?
Yes, it was quite interesting cases. Yeah, thank you. Thank you very much.
Thanks, Harsha. Saul?
Hi, name's Saul. I'm a neonatologist from Aberdeen.
Yes.
I just looked at your last sort of the algorithm. You put RV, normal, not normal, but you didn't put anything over LV. I think I was already preached by Neil to really assess both of them, and I completely agree that you really should not be starting anything without actually a proper basic echo structure and then assessing of the both functions. And if you really have the left ventricle failure, I was really sort of keeping myself no for the nitric until we've got it more or less running. Even if you have to have quite a high oxygen requirements, and then what Neil sort of taught me, let's put it this way, that a small dose of adrenaline rather the big one until you get, and then you actually have to do nearly about 6 hourly or 12, echoes when you really see that improvement on the function, and then you go, if anything, for the milrinone if that is needed. And then you consider, depending on the right ventricular function, the nitric oxide. But I wish to learn about vasopressin, because we never used, not necessarily we had a case that we need to use, but definitely something I'm looking for everybody to input of that. And it was really great talk. Thanks. I really appreciate that.
Okay, thank you. I think you were talking about this algorithm here.
Yes, correct.
I just wanted to stress that this is, all of this stuff down here is if you don't respond to nitric oxide. So this isn't about baseline echocardiography. It's about what you do if you're a non-responder. And I'm not sure I explained this particularly well, but my thoughts are, in addition to low blood pressure, we need to be doing an echo and assessing LV output, because we want to know why the blood pressure is low. And it matters whether, for example, it's RV dysfunction impinging upon the left ventricle, whether there's poor LV filling or poor contractility or whatever it might be. We need to understand why arterial blood pressure is low and also what's happening to LV output before we reach for any other agent. But I agree with what you're saying, that I think what you're saying is before you even think about nitric oxide, we should be doing a baseline echocardiogram so that we know what the hemodynamic phenotype is before deciding that we want to use a vasodilator rather than something to support the left ventricle or indeed the right ventricle.
Both. Yeah. Thank you. I really appreciate that.
Thanks very much, Sol. Bikesh and Sujit have both got their hands up. I think Bikesh, you were first. Is that right?
I'm not sure about that, but I'm happy to take.
Go ahead, Bikesh. Go ahead, Bikesh.
No, thank you, Nim. Thank you for such a lovely talk, and I cannot reinforce the fact the learning from it is just amazing, and this is what I try and do in the unit to tell my junior doctors that before taking that heavy machine out for nitric oxide, there are lots we can do, particularly optimizing the fractional residual volume, optimize the lungs. There's a lot you can do from ventilation point of view, rather than jumping into nitric oxide can create more problems than it can be benefit of. So we need to be very mindful in terms of how to use it and probably have a proper assessment. So my question over here, Nim, was again, and of late, I had a couple of patients, and that was all clustered together, where extreme preterm, 23-weeker, non-well optimized, 3 weeks of life, severe BPD, and then you see them, they behave very much like pH babies. You touch them, they desaturate. Anything happens, desaturate. Very much like pH. And when you assess, it all looks like a left atrial hypertension rather than anything else. You don't see, the RV has a good function, and the LV is hyperdynamic if at all, but there is you see that there is all the features of left atrial hypertension is there. Now it's a preterm babies. My experience for vasopressin is mostly limited to term babies. My question is, would you use vasopressin in preterm babies at all? And similarly, in such babies like this, I in the past had very good results, but just supporting this baby with dobutamine, and both the instance, I could see a significant difference in their hemodynamic status after a week of dobutamine itself, and it needed to do anything else. Just want to understand your experience and your views on this.
Okay, so I think you said this was the baby who was 2 or 3 weeks of age.
BPD and classical of left atrial hypertension type of feature, classical clinical pictures, and echo more of left atrial hypertension.
So my thoughts there are, firstly, you asked, would we use vasopressin in that sort of baby? We haven't done. We tend to use it in acute pH, where you have non-response to nitric, and in whom there are usually a low blood pressure with good LV output. So you want additional vasodilation because you've only got a partial no response to nitric, and you're trying to support the systemic circulation. So that's the combination. And usually, well, depends. If the blood pressure was okay, we might use milrinone as a second vasodilator. And then if the blood pressure was low, we would probably use vasopressin to try and support blood pressure. That's the situation, that clinical picture is when we would use vasopressin. So I have no experience in using it later on in the sort of baby you're describing. To my mind, that picture where you've got a baby who's, let's say, 2 or 3 weeks of age, has got pulmonary hypertension and raised left-sided pressures, left atrial hypertension is what you said. That would worry me that you've got a duct that's open. I don't understand why you would have left atrial hypertension unless you had systemic hypertension and left heart failure.
It's probably a secondary to diastolic dysfunction of the LVM, right? So LV diastolic dysfunction, you have systolic functions are preserved, LV diastolic. The duct in both the cases, the duct were absolutely smaller, and this all happened after giving them medical elimination of ductal treatment. And so I've never used, I always have reservations of using vasopressin in preterm babies as such. I've used them on term babies, particularly in setting of acute pulmonary hypertension with CDHs, as well as more as a rescue therapy to support their pressure, but I've never used them in a preterm babies. vasopress.
We do use them in preterm babies, but in the acute phase rather than the chronic phase. I don't know if other people have anything to add to
that. Can I come in?
Yes, please.
Thanks, Nim. Sorry, I'm just struggling to log in from my PC. This fantastic, outstanding talk as always. Because your case is quite interesting, because we have a similar case in the unit at the moment. Is an ex 25 weeker, 3 weeks old, and unable to wean from the ventilator. Echo showed moderate pulmonary hypertension. But when I did lung ultrasound, actually that was game changer, because we found a ventilator-associated pneumonia, quite impressive one. So we started antibiotics followed by DART, and now we're weaning him quite nicely. So I wonder if something else actually, like parenchymal lung disease, not particularly BPD, rather pneumonic changes or infection in the lung might be precipitating that. I don't know what your thoughts.
The baby's improved significantly after I started on dopamine. The only thing my colleagues were at that stage planning to start the baby on nitric, which probably, again, to Nim's talk, is could be detrimental, particularly in a setting of when you have LV dysfunction, left atrial dysfunction, and that results into left atrial hypertension rather than anything else. So it was probably, increasing the flow would be detrimental in such case. And dramatically, this is about 2 weeks, 3 weeks ago, and the baby is now extubated. And at some stage, I was so worried that this baby might not survive. As you touch, baby was on very high settings, 100% oxygen, till desaturating. I would show an echo at one of the teaching in next few weeks' time whenever I get. But my questions is, as a choice of your management, how do you approach such patients? If you suspect your left atrial hypertension type of picture, but those are the patients which I worry most. What are your choice of inotropes for such babies are? Because increasing your systemic vascular resistance and increasing with peripheral vasoconstrictor might be detrimental. Again, I'm not very comfortable using milrinone in preterm babies. The only thing I'm left is dopamine. And at times that has helped me to rescue me out of such difficult situations. So, I just want to understand what people use when they come across the situation.
I think it's go on.
Go for it, Nim, please.
No, I'm not sure I've got anything to add really to that sort of situation. But if I thought the main problem was the left ventricle, which it sounds as if it is, because we don't know why, but it seems as if it's left ventricular dysfunction, then there's some rationale for using a pure inotrope as much as you can. So it's either low dose adrenaline or it's dobutamine in that sort of situation to support that left ventricle. Depending on the blood pressure, you may or may not want to offload it with milrinone. If the blood pressure was okay, you might use milrinone.
Yeah. All right.
Yeah, I've used milrinone in a couple of preterm babies for babies who actually was resistant to dobutamine. So you can try dobutamine first. If it's not working, I think it's worth trying milrinone, as long as your systemic pressure is okay.
Thanks,
thank you, man. So my experience was that dobutamine, if you identify the pathology right, dobutamine has got its, benefits. And if it's used in the right type of patient, it could be harmful. But, such patients like this, in every instances, I had significant benefits from just use of dobutamine.
Thanks, Bikash.
Thank you.
No, thank you. I'm conscious we're going to have time, but we're also going to get Sujit, and Anne-Marie's got her hand up as well.
Hi, Nim. Thank you so much for the talk. Nim, with regards to vasopressin, in theory, it would seem like an ideal agent because it reduces your pulmonary vascular resistance, increases systemic vascular resistance. But I fear that, case series and case studies may be the only evidence we may get, especially given that how tricky it is to do trials with PPHN and with, the MINT trial also not progressing. But do you envisage randomized trials, especially in the area of pulmonary hypertension and sort of looking at vasopressin, because that is probably one of the things which will increase clinician confidence in using vasopressin?
Yeah, no, I agree with you. We do need better evidence than we've got. And what worries me about these small case series is that, can you imagine that if you treated 10 or 12 babies with an agent and it didn't have any beneficial effect, or worse still had an adverse effect, whether you'd actually bother publishing it, and even if you tried to publish it, whether anyone would accept that publication. So there's a huge concern about publication bias when you see case series like that. And every time I see one of those, I think there must be at least 2 or 3 which aren't published, not supportive. So I think we're right to be cautious about it. In terms of your question about RCTs in pulmonary hypertension, they are difficult. Well, RCTs in newborn babies, especially when they're acutely unwell, are difficult. But I can imagine that a small RCT, call it a pilot if you will, either vasopressin head-to-head with the noradrenaline or vasopressin versus placebo in nitric-resistant babies, you wouldn't need a huge number to be able to look at short-term physiological changes. Let's say, for the sake of argument, 20 in each group, that might be enough to look at oxygenation and hemodynamic response in that group. So I think it's perfectly doable. And if we wanted to embark on that as an inner community, it could be a multi-center trial of some kind. And it shouldn't be that difficult in terms of, I don't think it's ethically difficult. It's not something that's a difficult sell to parents either. So I think that would be possible. I think the difficulty is when you're trying to do large randomized controlled trials, looking at 200, 300 plus babies, PDA type of trials, that is very difficult, very expensive. A lot of studies are terminated early, and it's difficult to justify that much spend when, a bit like the Baby Oscar trial, you get a result many years down the line when the landscape of how you manage ducts has changed, which is unfortunate.
No, perfect. Yeah. No, thank you so much.
Thanks, Sujit. And Anne-Marie?
Yes, just very quickly, Nim. I think Neil would probably agree with you, say we don't have a huge amount of experience of using vasopressin in Glasgow, and it's possibly because we've been very well supported by an ECMO service. I think particularly in the context of very sick babies with pulmonary hypertension, maybe including the diaphragms. So I was just trying to envisage how you use it, because I think it is something we're going to be exploring more, I would imagine. And I think a clinical trial with a very prescribed group of patients sounds interesting. So I guess my concept is you've got a baby, term, severe pulmonary hypertension, defined, not LV dysfunction. They're on nitric and they're profoundly hypoxic with a big right to left ductal shunt with borderline blood pressure, low blood pressure. That's when you would use it, and try and balance your ductal flow a bit more and hopefully improve systemic support.
Yeah. So my rationale there, Anne-Marie, would be that you've got persistent hypoxemia, severe hypoxemia. Yeah. You've done what you can with the best pulmonary vasodilator you've got, which is nitric. The baby's still got both hypoxemia and a PPHN physiology picture. So what you want to do is try and improve your pulmonary vasodilation. So you're looking at additional pulmonary vasodilation, and that is either, we're limited here, either milrinone or sildenafil or vasopressin or noradrenaline. Those are the only agents I know that have been suggested as having some further beneficial effect in terms of pulmonary vasodilation. And then I would tailor my treatment according to blood pressure and LV output and LV function. So I think if you've got low blood pressure, you can't use anything that's going to cause systemic vasodilation. So that excludes milrinone and sildenafil. So that leaves you with the vasopressin and noradrenaline to use, assuming your left ventricular output is okay. Because I would worry using anything that's going to cause intense systemic vasoconstriction when you're already starting out with low LV output. But
so there might be a small number of patients where it's applicable, but you found it very successful at times.
I don't know about very successful. We have used it with good effect in terms of raising blood pressure, because that's what we wanted to do in that situation as well. Because I think you need decent central blood pressure if you're going to perfuse your coronaries and improve ventricular function.
Absolutely. It's very interesting. Thank you.
Yeah, and just on that as well, I think you're right, Nim. It's the potential benefits of that are not just direct pulmonary vasodilating benefits, but it's that by improving systemic blood pressure, you may be improving coronary perfusion. There's also this theory that you know, in a resilient left ventricle, when you're increasing the left ventricular afterload, you're improving left ventricular function. There may be something about increasing left ventricular diastolic pressure and how that affects septal morphology and function as well. There's some animal data to kind of support that. So that's where I kind of think sometimes this role of supporting the systemic vascular resistance in that setting of what is more of a pure, as you said, Anne-Marie, high pulmonary vascular resistance RV dysfunction setting may have a role. Yeah.
It's interesting. I think there may be a group where it would be, I've thought before, theoretically it's a nice idea.
Yeah, but it's a subgroup within a group, isn't it? It is a specific phenotype, as Nim was describing.
And that's the challenge of trials, isn't it? Yeah.
Great. Okay, guys, we're 1:15, so not surprisingly, because it was such a fantastic talk, we had lots to discuss afterwards, but we'll perhaps draw to a close there. I'm sure if anybody has questions, then we'll be happy to be approached with that. But just to thank Nim again for just fantastic presentation, and just reinforces the quality of the discussion and that we have at this meeting and at this group. And thank you all again for attending and joining us. Have a great weekend, and looking forward to next week. Thanks, everyone.
Thank you.
Thanks. Bye.
Thanks, Nim and Neil. Thanks, everyone. Bye.
Thanks, guys.